this module, we're going to discuss ICD-10, chapters 1 through 11. In risk adjustment, that sequencing doesn't always apply, but because this is generally a refresher on ICD-10 coding, we're going to go over those different sequencing guidelines. Chapter 1 is certain infectious and parasitic diseases, which are discovered by going through code ranges A00 through B99. In ICD-10-CM, there are several categories to classify HIV. We have B20, which is the HIV disease, R75, which is inconclusive lab evidence of HIV, Z20.6, contact with and exposure to HIV, and Z11.4, which is the encounter for screening for HIV, Z71.7, HIV counseling, and Z21, which is asymptomatic HIV infection status. Instructions indicate to code only confirmed cases, and that confirmation does not require a positive test or lab result. The provider's diagnostic statement that the patient has HIV is sufficient. In ICD-10-CM, code B20 is used for symptomatic HIV patients. This is for a patient who has had any of the opportunistic infections associated with HIV. People with advanced HIV infections are vulnerable to infections and malignancies that are called opportunistic infections, and they're called that because basically they take advantage of the opportunity of that weakened immune system. The code for HIV is synonymous with the term acquired immune deficiency syndrome, or AIDS, and the age-related complex, or ARC. You would use an additional code to report any manifestation of AIDS or HIV infections. Once a patient has been diagnosed, an HIV code of some type should be on every claim form that patient has. It is the sequencing, though, of those codes that may change. Sequencing depends on the reason for the patient encounter. So let's say a patient comes in for tuberculosis due to HIV. In this case, the B20 is coded first. If the patient has AIDS and they sprain their ankle and come in with no other complaints, then that reason really for the encounter is the sprain. So that sprain is first, and then we use that B20 secondary. If a patient is admitted with an HIV-related condition, the principal diagnosis should be B20 for the HIV disease, followed by any additional diagnosis to report that related condition. If a patient with HIV disease is admitted for an unrelated condition, like they had a traumatic injury, the code for that unrelated condition, that traumatic injury, should be utilized first as the principal diagnosis. And then other diagnosis would be B20, that HIV code, followed by any additional diagnosis for any HIV-related conditions. Code Z21 is only used for patients who have never exhibited a sign or symptom of that active disease. Once you move out of that and go into that B20, you can never go back and use that Z21 again. Even if the opportunistic infection is treated and the patient gets better and seems fine, once they're at B20 and they've been assigned B20, they can't go back to using Z21. That can't be assigned again going forward. To code contact with and exposure to HIV, you would assign code Z20.6. Depending on your specialty, you may see this come up more often, like if you have healthcare workers that are exposed during some sort of treatment. So here's an example. Patient is tested by his internist and was positive for HIV without symptoms. If you look at that excludes one note shown here, it lets you know you cannot code acquired immunodeficiency syndrome contact with or exposure to HIV, HIV disease, or inconclusive laboratory evidence of HIV. R75 is for nonspecific laboratory evidence of HIV. Depending on the kind of facility you work at, you may not see this very often. Children born to HIV mothers will actually have false antibodies and will potentially test positive for up to 18 months. Other tests have to be utilized to kind of confirm if they do or do not carry that HIV. You may also see it when it comes in the lab. Antibody test results for HIV are accurate more than 99.5% of the time. Before you get the result, the test has usually been done 2 or more times. The first test is called an EIA or ELISA test. And before that positive test result is reported, it is confirmed by another test called the Western blot. This is why home test kits can't really tell you if you have an HIV infection. That sample really has to be collected and analyzed by a laboratory. And sometimes pregnant women may actually have false or unclear test results just because all of the changes going on in their immune system. When a patient is seen or is being seen to determine their status, if they have HIV, you would assign code Z11.4, which is encounter for screening for HIV. And then when they return to be informed of their HIV test result, and the test is negative, you would assign code Z71.7 for HIV counseling. Not all infections are contained in Chapter 1, and in those instances, the infectious organism is not identified in the infection code. In those circumstances, you would also assign a code from Chapter 1 to identify the organism. A code from category B95, B96, or B97 is to be used as an additional code to identify the organism when present. These categories are provided to use supplementary or additional codes to identify the infectious agents in diseases classified elsewhere, such as sepsis. In the term "in diseases classified elsewhere," if you see that, it's a good tip to look to figure out an order for the code. And that code's telling you to go out and classify diseases that caused it first. These codes were expanded to include many codes for specific types of drugs. Some code examples are Z16.11 resistance to penicillin and Z16.21 for resistance to vancomycin. Sepsis is a severe illness in which the bloodstream is overwhelmed by bacteria, and it's caused by an infection that can begin anywhere in the body, like a small cut. Sepsis is often life-threatening, especially in people that are already having weakened immune systems or have some kind of chronic illnesses. It's really been on the rise across the country. They believe that the spike in cases may be due to the number of antibiotic overuse in the country, and from patients who are being prescribed antibiotics and not taking that full course of antibiotics. And these resistant infections make sepsis a lot more difficult to treat. Sepsis refers to an infection due to any organism that triggers a systemic inflammatory response. All codes with sepsis in the title include the concept of systemic inflammatory response syndrome, or SIRS. For cases where sepsis, where they do not result in any associated organ dysfunction, just a single code for the type of sepsis should be assigned. Severe sepsis codes should not be assigned unless the provider documents severe sepsis or there's an associated acute organ dysfunction. If a patient has sepsis and an acute organ dysfunction, but the medical record indicates that that acute organ dysfunction is related to something else, then you would not assign that code for severe sepsis because that acute organ dysfunction is related to something else. You will note that the coding for severe sepsis requires a minimum of 2 codes. First, a code for the underlying systemic infection, followed by a code from subcategory R65.2 for severe sepsis. If we don't have that causal organism documented, you would just assign code A41.9 for sepsis unspecified for the infection. You would also need to code for the associated acute organ dysfunction. Septic shock is a circulatory failure associated with severe sepsis, and it is represented by a type of acute organ dysfunction. For all cases of septic shock, the code for the underlying systemic infection should be sequenced first, followed by the code R65.21 for severe sepsis with septic shock. Septic shock does include the presence of severe sepsis. Any additional codes for other acute organ dysfunctions should also be assigned. The sepsis guidelines are pretty technical, and you have to reference them pretty frequently until you become more familiar with those rules. Bacteremia is the presence of viable bacteria in the circulating blood. This may or may not have a clinical significance because there is often harmless transient bacteria following if the patient's having dental work or minor medical procedures. However, it could be more of a problem in patients that are immunocompromised or younger. The concern with that occult bacteremia is that it could progress to a more severe local or systemic infection if it's left untreated. The term bacteremia is coded R78.81. There is an excludes one note, meaning that never code here for sepsis with an instructional note leading you to the code range A00 through B99. Sometimes sepsis is the result of a post-procedural infection, and that would be considered a complication of medical care. In those instances, you would report the complication first, followed by sepsis following the procedure, followed by any additional codes required to identify the specific infections. If sepsis or severe sepsis is documented as associated with a non-infectious condition, and that condition meets the definition of a principal diagnosis, you would code the non-infectious condition first, followed by the code for the resulting infection. Pay attention to the sequencing here. For other infections in which SIRS is present but sepsis is not in the code title, you would use code R65.10 or R6511 for systemic inflammatory response syndrome. Codes for sepsis and septic shock associated with abortion, ectopic pregnancy, and molar pregnancy are in Chapter 15. OB coding is a little bit different. They oftentimes take priority over other codes. Colonization means that MSSA or MRSA is present on or in the body without necessarily causing illness. MSSA stands for methicillin susceptible Staphylococcus aureus and refers to all of the antibiotic sensitive strains of Staph aureus, which is a common bacteria that can cause a wide variety of infections, both in hospital and in community environments. In other words, MSSA is the common type of Staph aureus that causes most Staph aureus infections and can be treated with penicillin-type antibiotics. By contrast, MRSA stands for methicillin-resistant Staphylococcus aureus. MRSA is a subgroup of Staph aureus that is resistant to a range of antibiotics, including penicillin antibiotics, and it first appeared in 1961. Soon after the introduction of the antibiotic methicillin, which is no longer used. Since then, MRSA has spread around the globe and has been particularly associated with hospitals. In general, MRSA is no more likely to cause an infection than MSSA, and they're both can cause localized or minor infections and occasionally generalized or severe infections. Because MRSA is resistant to a wide range of antibiotics, people with severe MRSA infections tend to remain ill for longer. For very severe life-threatening infections, the risk of death is about twice as high with MRSA as with MSSA. When a patient is diagnosed with an infection due to MRSA and that infection has a combination code that includes that causal organism, such as sepsis or pneumonia, you would assign the appropriate combination code for the condition, such as A4102, which is sepsis due to MRSA, or code J15212, which is pneumonia due to MRSA. Do not assign code B95.62, which is MRSA, as the cause of diseases classified elsewhere, because we are classifying what is that condition. Don't also code Z16.11, resistance to penicillins. That's not to be used as an additional diagnosis. When there is documentation of a current infection, such as a wound infection, a stitch abscess, or a UTI due to MRSA, and that infection does not have a combination code that includes that causal organism, you assign the appropriate code to identify the condition, and then you use that B95.62, which is MRSA, as the cause of diseases classified elsewhere for the MRSA infection. And again, you still don't use that Z16.11 for resistance to penicillins. You would assign code Z22.322 carrier or suspected carrier of methicillin-resistant Staphylococcus aureus for patients documented as having MRSA colonization. And you would assign code Z22.321 for carrier or suspected of methicillin-susceptible Staphylococcus aureus for patients documented as having MSSA colonization. Colonization is not necessarily indicative of a disease process or as the cause of the specific condition the patient may have unless documented by the provider. Zika virus, which is transmitted primarily through mosquito bites, is risky because it can cause birth defects such as microcephaly. Symptoms of Zika virus are often mild, if symptoms even appear at all. Some common symptoms include fever, rash, joint pain, conjunctivitis. Only a confirmed diagnosis of Zika virus as documented by the provider can be coded. A provider's statement that the condition exists is sufficient. You do not have to have supporting lab testing. Zika virus is reported with A92.5 unless it would be stated as probable, suspected, possible, in which case we would just use those signs and symptoms. So if a patient comes in and they have suspected Zika virus and they have fever and rash or whatever, we would just code the fever and rash unless the provider definitively states that they have Zika virus. Next, we're going to cover neoplasms, which is C00 through D49. When we're coding for neoplasms, that documentation has to include the morphology, such as if it's benign, in situ, malignant. Always make sure to look up the term first. Don't just jump to the neoplasm table because there are certain conditions that have listings in the alphabetic index for that specific type of neoplasm. If there is a malignancy, the secondary or metastatic site should also be reported. All sites should be documented and coded. The order of the codes, though, will be driven by those sequencing instructions that we have for ICD-10. We'll go over those in a minute. In the neoplasm table, you are not always going to find the complete codes. So there's many times you're going to have to go to that tabular listing to verify additional digits. Which is true particularly for laterality as well as some skin conditions like basal cell carcinomas versus squamous cell carcinomas. The neoplasm table has 7 columns. The first descriptor is followed by the type of neoplasm, and there are 3 columns for malignancies. Those are their first 3. Primary malignancy is where the cancer starts. It hasn't spread anywhere from there. A patient can have multiple primary sites in the body. Secondary malignancy is when the cancer has spread to an organ or site from somewhere else. The provider might document it as METS or metastatic or 2 or secondary. Carcinoma in situ is when the malignancy is encapsulated and it might get larger, but it's not going to spread to other sites. After that, we have our benign or non-malignant, non-cancerous ones. Uncertain behavior is a neoplasm that has a specific pathological diagnosis. This is a lesion whose behavior can't be predicted. It's currently benign, but it could develop something where it transitions and transforms over time. Some examples of lesions of uncertain behavior include congenital giant pigmented nevus, dysplastic nevus. Actinic keratoses are also a skin lesion of uncertain behavior, and they have actually their own specific ICD-10 code. So you don't go to the neoplasm table for that one. You would just look under actinic keratosis. Unspecified is our last column, and those are ones that, for example, we haven't sent out to pathology, and the documentation in nowhere specifies what type of lesion it is, so we would use an unspecified code. If the reason for the encounter is to diagnose when a malignancy may be present, you would assign the code for the signs or symptoms until that final diagnosis is made. So let's look at an example. During a routine examination, physician found a suspicious mass in the upper outer quadrant of the left breast of a female patient who also has a history of breast cancer. He schedules a biopsy of that breast lesion. The first code that we're going to report is that unspecified lump of the breast, N63.21. But that history code is important too, because that might drive some medical necessity. So we want to use that as well. Z85.3, personal history of primary malignant neoplasm of the breast. When treatment is directed at a malignancy, that malignancy is used as the principal diagnosis. However, if that encounter is solely for administration of chemotherapy, immunotherapy, or radiation therapy, we use those codes first. Remember, we always want to code for what drove that patient encounter. What was that chief reason that the patient came in that day? Once that's been established, then we follow our coding guidelines. So here's an example. Patient underwent removal of upper lobe of the left lung due to lung cancer after a mass was discovered. The correct code would be C34.12 for malignant neoplasm of upper lobe, left bronchus, or lung. This is an area where coders tend to get confused. If a treatment is aimed at that secondary site, it's okay to use that secondary site as the principal diagnosis. So here's an example. Treatment was directed at secondary site of the liver, so it's the first listed code. The cancer spread from the pancreatic duct, so the pancreatic duct is the primary site, but it is, in this case, the second listed code because we're focusing our treatment today on that site of the liver. This is a different rule than we're used to. When the admission or encounter is for the management of anemia associated with the malignancy and the treatment is only for the anemia, the appropriate code for the malignancy is sequenced first, and then that secondary code is D63.0, anemia and neoplastic disease. However, if dehydration is the reason for the encounter, it would be sequenced first, then the code for the neoplasm. If you look at code D63.0 in your ICD-10 book, there is an instructional note leading you in the right direction. When the admission or encounter is for treatment of the complication resulting from a surgical procedure, then you would count the complication as the principal or first listed diagnosis if treatment is directed at resolving the complication. For example, patient was treated for sepsis following surgery for the removal of a malignant tumor of the lateral wall of the bladder. First listed would be our sepsis code, and then secondary, we would utilize our malignant neoplasm code. When an episode of care involves the surgical removal of a neoplasm, either primary or secondary, that is followed by chemotherapy or radiation treatment during that same encounter, that neoplasm code would be sequenced first and then the codes for the chemotherapy. But again, if that chemotherapy radiation is that sole encounter, that's the only reason they're coming in, we would assign Z51.0 for radiation, Z51.11 for anti-neoplastic chemo, or we would assign Z51.12 for anti-neoplastic immunotherapy for our primary. A patient may actually have more than one malignant tumor on the same organ. So these tumors represent different primaries or metastatic disease depending on the site. You should only use Z80.0, disseminated malignant neoplasm unspecified, for those rare occasions when the patient has advanced metastatic disease and no known primary or secondary sites are specified. Keep in mind that code C80.1 for malignant neoplasm unspecified is basically the same thing as saying unspecified cancer, so it should very rarely be utilized. Multiple code subcategories exist for coding malignant neoplasms of the skin. Category C43 contains codes for malignant melanoma of the skin, and then the subcategories break down by site and laterality. So they include basal cells, squamous cells, and then other specified and unspecified codes. For example, patient returns to the dermatologist to discuss removal of squamous cell carcinoma on his right ear. The appropriate code is C44222 for squamous cell carcinoma of the right ear and external auricular canal. If you look this up in the neoplasm table, it's not going to give you all those digits. You'll look under skin, and then you'll go under, where was this site, the ear, and then it will give you part of the code under malignancy, but you have to go to your tabular list to find out what those last digits are for squamous cell. Sequencing rules are as follows. If the reason for the encounter is for treatment of malignancy primary, you would assign the code for malignancy as the principal diagnosis. When the encounter is for treatment of the metastatic site, then the metastatic site would be listed as primary. As per the coding guidelines, anything from those OB settings, childbirth, puerperium, etc., are always sequenced as the principal diagnoses. When a patient is diagnosed with a pathological fracture due to a neoplasm and the focus of treatment is aimed at that fracture, the principal diagnosis is actually M84.5 for pathological fracture in neoplastic disease, and then secondary is that code for the neoplasm. So first for fracture, if we're treating the fracture as fracture, and then secondary would be our code to specify what type of that neoplastic disease the patient has. So here's an example. Patient is treated for pathologic fracture of right tibia due to neoplasm of the right tibia. First, we use M84.561A for our initial encounter of the fracture, and then C40.21 malignant neoplasm of right lower limb. You can only code for a malignancy as long as treatment is aimed at that malignancy. Once that treatment's been completed and there's no more evidence of malignancy, we utilize our personal history codes. So for example, if we excise a tumor and we're not focusing any more treatment at that site, it would be a history of. Some providers kind of feel that once a patient has been diagnosed with cancer, they're always going to have that cancer code, but really once that cancer is eradicated, they're no longer receiving treatment for it. It's a history of code. For example, a 56-year-old male was seen in follow-up after removal of a prostate 3 years ago for malignancy. That principal diagnosis, if he's no longer getting any active treatment for that, there's no more malignancy, Z85.46, personal history of malignant neoplasm of prostate. Chapter 2 also contains codes for leukemia, multiple myeloma, and malignant plasma cells. These codes contain language for with or without remission, and that's based on the provider documentation. Leukemia is a type of cancer that affects the blood and the bone marrow, that spongy center of bones where our blood cells are formed. The disease develops when blood cells produced in the bone marrow grow out of control. In addition to the codes for malignancy and remission, there's also codes for personal history, such as Z85.6 for personal history of leukemia and Z85.79 for personal history of other malignant neoplasms of lymphoid and related tissues. The colon is also called the large intestine. The ileum connects the cecum in the lower right abdomen, and the rest is divided into 4 parts. There's 2 flexures, hepatic and right colic flexure, which is between the ascending and transverse colon. Splenic and left colic flexure between the transverse and descending colons. And then, for example, if Jim's being seen for a neoplasm at the hepatic flexure and his pathology came back as benign, we would assign code D12.3, benign neoplasm of the transverse colon. Neoplasms of the breast are defined by quadrant, so we need to know those quadrants for the most specific codes to utilize. If it's unknown, which can happen in post-mastectomy reconstructive, plastic surgeons don't always treat the cancer, so they don't know what code to use for the quadrant, because once they've got in, the breast is usually removed. They can look at the other provider's documentation or their past history to get a more specific quadrant, and if not, they would just have to utilize the unspecified breast code.